Thank you, Tom. Let me start with a bunch of thank yous. Thank you, Tom. Thank you, Marcia. Thank you, everybody from Cyprus. Every time I come here, I learn something. And my background, Tom's right, I was in politics for a little while. By the way, that whole Medicare thing, government can't run government. They're certainly not going to run healthcare, so that's my 2 cents on that. However, in having said that, as I said, I always come here and I learn something. My early life actually started in the theater, and having been in the theater, the first thing you're taught is to look for the hot spot in the light. Of course, that was also 45 or 50 years ago. I watched Tom, and Tom moved to behind the podium. So the question is, where do I go? Ron was out here, and Tom was over there, and I decided that 45 years ago, this is where I should be, and today I should be over there, because otherwise I'm just going to blind you. I'll move back a little bit. But learning is a good thing, and you should learn everything that you can possibly learn about virtually everything that's going to happen in this room and over the course of the next day and a half or 2 days. By the way, the other thing that I learned in the theater, you never, ever, ever want to follow an animal, a small child, or a lawyer. However, Ron, I am grateful because it could have been Adam. That's another story. And it seemingly I follow Adam around the country, and of course I'd be out of time by now. So let me talk a little bit about what it is that OneCall does and why we are successful at what we do. But I'm going to take it another step. I'm going to move this into not just learning about this particular program, this program and what it does. I'm going to talk about the good, the bad, and the ugly with this, and I told Tom this from the beginning, and we're going to use actual Cypress numbers to show you that. So basically, I'm going to give you a quick little thing why you need a program. I'm not going to read all of these slides. I have a half hour. He had 45 minutes. I need a half a day. That's the story. So I'm going to be whipping through these slides, and having come from New York, trust me, I can do it. I can talk faster than anybody else you want to know, trust me. And having said that, I'm going to do a little bit about our history. I'm going to talk a little bit about products and services and what it is that we do. I'm also going to speak a little bit about what the potential versus the actual is. And that's really the learning point. It's not just what you learn, but it's how you put that to work for you and being wise about it. So very, very, very quickly, and I'm not going to go through all of these slides, it costs a lot of money. Healthcare costs a lot of money in this country. No matter what you do or how you shake it, it costs us a lot of money. So what does OneCall do? Basically, we steer. That's what we do. We go out and we contract with providers across the country, and we tell them that if they can give us a little better price than they're giving to everybody else, we're going to drive business to their direction, and we can do it. And I'll get to that in a second in terms of history. So how does it work, and why should you be using it? And then I'm going to shut up.
Meet Mark. Saving money is important to Mark. Whether he's taking his family out to dinner, buying clothes for the kids, or searching for a local plumber, it's important to find the best deal without sacrificing quality. But when it comes to healthcare costs, Mark, like many other Americans, is used to being told where to go for his medical needs, so he doesn't usually shop around for the best price. What if there was a way for Mark to save his family up to 80% on a common type of healthcare cost? Diagnostic imaging. That's where OneCall can help. Every year, more than $300 billion is spent on radiology services in the US. And that number is continuing to grow at a rapid pace. Many people require multiple diagnostic scans a year as part of their care plan. Most, like Mark, are referred to a hospital's outpatient division by their doctor. There, the hospital charges an average of $2,900 for an MRI, and other services are even more expensive. But because Mark uses OneCall, Mark contacts OneCall's concierge scheduling service as soon as the appointment is needed. And we search our network of nearly 3,000 nationwide radiology partners to find the most convenient location for his home or office. Then OneCall will schedule the appointment for the exact same procedure for hundreds or even thousands of dollars less, allowing Mark to sit back and enjoy the savings. Best part is that OneCall's services are included in your existing benefit plan. All you have to do is call us to schedule an appointment. So if you're like Mark and want to save more on your diagnostic needs, give OneCall a call today. and enjoy access to the best radiology care in the nation for less.
Okay, it's not diapers, but it is shopping, and you should all be doing it. It's real interesting to learn that you can have, and I don't recall who it was, whether it must have been Ron, who talked about comparing the prices, and obviously if it costs more, it must be better. That's not true. I mean, it's just simply not true. And so if you're going to the hospital and you want to spend that money, and I'll tell you why you're going to do that, it's because your doctor said so. That's a behavioral change, by the way. He has a reason to send you there. So when you get moved from the hospital setting into the freestanding setting, trust me, we're disturbing the system. And nobody likes that. But it's the same service. In fact, more often than not, what you're going to find out is that the reading radiologist for the study that was done in the hospital is the same reading radiologist that's doing the study at the freestanding. So it's not so much about knowing that, it's about putting it to work for you. It's about being smart about the things that you learn here and being able to make those all work together. And I'm going to touch on that in a couple of seconds. So one call, just so that you know. And how do they get those kind of prices? They started out in the workers' comp arena, which is actually where I came from, back in 1993, doing nothing but MRI, CT, and PET for workers' compensation only. I think when I came on board, I don't recall exactly, I think we were about 290-ish or so people doing about $50 million worth of business. Today, this company has over 2,800 employees doing $1.3 billion worth of business. We have some muscle. We can go in and negotiate by telling them, we'll drive business to you. And that's how those prices happen. So we started out solely in workers' compensation, and it didn't take all that long. All of a sudden, they hit the wall. They owned the market. They were the 800-pound gorilla in the room, if you will. And so they said, well, so what do we do next? And they decided to move over to group health. When we did this, the only thing that we moved over was that which we started with, which was high-end radiology, MRI, CT, and PET. As things progressed along, we've now sort of made our footprint there. And so now what One Call is doing is said, so what's the next level? Where do we go? And so we introduced transportation into the Medicare and Medicaid space, all coming under the guise of group health. I'm going to talk more about that in a half a second. How well did we do all of that? You got all of these products going on out there. You got a large company making a little bit of money, make no mistake about it. How are we doing? And this is our report card on it. So in the world of what we do, which is to put providers in place, qualified, having been credentialed to the nth degree, to make sure that you're getting value for your dollar at the best price you can possibly get. More importantly, it's outcomes based. Remember, we come out of the workers' comp world where everybody is judged by return to work because that's your biggest cost. Get that employee back to work as quickly as you possibly can. The same holds true in the group space. How does the program work? I get to shut up again.
Need to schedule an MRI, CT, or PET scan? One Call makes it easy to save money on high-quality imaging services. All you have to do is call our scheduling team. We'll confirm your doctor's order and your benefits, helping you find a provider that is convenient to you. Once a facility is chosen, we'll schedule the appointment while you're on the phone. It's as simple as that. Access to One Call's network can save you up to 50% on diagnostic imaging charges.
So pretty simple, that's exactly how it works. Basically, the referral will come into us from a variety of different sources, either from the member, it could come in from the provider, on occasion it'll come in from the physician, and sometimes it'll come in from the URUM company, whoever's doing the pre-cert on it. But basically it's going to come in, we're going to verify the script with the physician because nothing sucks more than doing the wrong study. It was the right leg, not the left leg, stupid. Yeah, I got it. Make sure you're doing the right study. Then make sure that it's covered. So we're going to call Cypress. We're going to check on the benefit level. Is there a deductible involved? Is there a copay involved? And we'll handle all of that. And then we're going to call the member and find out where they want to have it. They want to have it near their home, they want to have it near work, they want to have it near their aunt in Florida, wherever it is that they want to have it, figure out the best possible facility, not necessarily the lowest price, the best possible facility to do that study at the best price that we can then find for that. So it's outcomes-based, it's also price-driven, and now what happens is that three-way call happens. And we bring everybody together, and we have that three-way so that the member now knows exactly what it is that they're up against and can ask everything that they ever wanted to know but didn't really want to ask. Where am I going? What time do I have to be there? What's going to happen afterwards? Is there patient responsibility? How much am I on the line for? I think I've already covered my deductible. It didn't show up there. Oh my goodness. Everybody's worried about a whole bunch of different things. It all happens on that one phone call. Ultimately, at the end of all of that, the patient's happy. Their hand has been held through the entire of the process. The bill is coming to us. We are then going to reprice the bill and send it on to Cyprus to have the bill adjudicated. There is nothing else. There is no balance bill. It's a global bill. It covers everything. It covers the technical charges, it covers the professional charges, and any of the ancillary charges that could be associated with that particular study. That's what we negotiated. And it's contractual. This is not reference-based pricing where you say, well, would you accept a percentage of Medicare? Of course they will. But there's no contract in place. So at any point in time, they can say, yeah, I don't think so, not today. So ultimately, you don't really have reference-based pricing. You actually have something that's written down on a piece of paper and is binding because there's a contract in place. Basically, the program is real simple to put in. You're going to load our TINs. We're going to interface with whomever the clearinghouse is to get the claims adjudicated. We are going to check all the benefit and the eligibilities. We're going to verify the script. We're going to go through everything that I just mentioned to make sure that this happens, and then we are going to steer them from the high-cost hospitals into the lower-cost facilities. I'm now going to get into a little bit of how that works. I've got 17 minutes to do this, so work with me here. This is a list of our call centers. We begin at 8 a.m. Eastern Time and go to 8 p.m. Eastern Time to make sure that we're covering all of the time zones. As far as cost savings is concerned, it's going to vary slightly geographically because, again, we're covering the nation. So let's talk about cost savings real quick. There's two types of cost savings, hard cost savings and soft cost savings. Hard cost savings is pretty simple. That's that which is documentable right then and there. Here's the physician's price, here's our price, do the simple math, now you've got it. Pretty simple. Soft cost is a little harder to get to. If Tom is on his 4th MRI, and every single one of them, he went to the hospital, the previous 3. And now we move him to a freestanding. That is a behavioral change. And what we get out of that, the savings that we get out of that, you couldn't have had otherwise. So it's not just against the provider charge, it's the fact that we've now changed his behavior. And so it affects everything going forward. Aside from that, you also have the global billing aspect of this. So there is no balanced billing. That counts for something. And then there's the utilization and how we move the utilization, which I'm going to speak to in a second as well. In order to do a proof of concept, what you need is to look at your data. It's your data. Take a look at it. Where is your radiology spend going? I contend a lot of it's going to the hospital, and it shouldn't be because it's hurting the cost against plan. If there's an out-of-pocket expense for the member involved, then it's also hurting their out-of-pocket. So you need to look at that. This is an excerpt from an actual cost savings analysis. And what I'm going to caution, I'm not going to go through the numbers, but I will caution you with this. You'll notice that I put in a 55% steerage differential there, and it's there because that's about what the success rate is for all that's going to come into us. About 55%, we are going to be able to move. Now, when you start talking about the numbers that we're talking about, that's a huge number over the cost of your entire employee population. This is an actual, again, comes from the same report, but this is what cost savings could look like. But again, that's only if we're actually successful in being able to steer them. This is an actual cost savings report for Cyprus. Are they in the room? Where's Tom? Yes, no? No, is that group in the room? Okay. Good job, Tom. Pointed everybody else out, but no, don't worry about it. Thanks for reading that before you put it up there, Tom. But this is an actual report. And it comes down to education. In order to get those, you got to educate, and educate. They, Cypress, can do a great job with educating you on a program just like this, and there's many, many other programs out there. But unless you take that, you being the employers, you being the consultants, you being the brokers, and understand what that's doing, then it's not going to be successful at all. I'll come out and help you. Or Brian. Brian, are you here? Yes, okay. Or Brian, we'll come out and we'll do the benefit fairs, we'll do the open enrollments, we'll make sure that they have all of the collateral that they need. We understand how hard it is to be able to educate the membership on what they have. This is Cyprus. This is the history with one call. Now, the truth of the matter is, and I'm about to get into this, and this is not at all to embarrass Tom, Marcia, or Cypress, but to explain to you why the knowledge is one thing, the wisdom is yet still another. So there's been growth over the years, and ultimately, what they should have been doing was making everything work together a little better. Of course, they can't really do that. They can educate you on that, but you are the ones who have to make sure that that's all working together. So the anticipated utilization for Cyprus, based upon that which has the one-call program on, was about 1,548 MRI CT PETs. That's based upon the membership and the amount of accounts that they had. The average savings came out to about $834.49, sorry. I say about, it's exact, per scan that was done. But they left 1,253 scans on the table. Now, you wonder why that happened. Some of it's steerage, some of it's geography, but that's really ultimately what I want to talk about. So what's the potential versus what they actually did? And there's two major reasons why something wouldn't happen. There's a lot of other reasons, but I only have time, because I'm down to 12 minutes now, I only have time to talk about these two. But it gives you an idea of what I'm talking about applying the wisdom to the knowledge that you gained here. So first there's urban-suburban. This is the one-call network. You'll notice that for the most part, everything east of the Mississippi is about as solid as it gets. The south is actually full. Those areas you don't see anything. There just isn't anything. And the west coast is in all of the populated areas. The problem area with this network right now is Montana, Wyoming, North Dakota, and South Dakota. That little quadrant up there. The only thing that's up there are cows, and we don't contract with cows. In having said that, this is the one-call network that will supply to just about any one of our TPA clients so they can go over this with their clients. This is the actual. We're not hiding this at all. The reason, how do I go back? Yep, there you go. The reason that this is what we give out is because we want to make sure that we're avoiding self-referral. Because once that member goes to that particular provider because, oh, it's in network, everything comes off the table. Think about it. Why would a provider give up more than he had to? Right? If the call's coming from us, he's contractually bound to that price. If you walked in thinking it's in network, guess what? Everything's off the table. Again, it's about education, education, education. That's how those numbers begin to slip. This is a big problem. Pre-cert. I understand pre-cert. I understand how it happened, having come out of the workers' comp world. You go back into the late 70s, early 80s, mid 80s, up and through the 90s, overutilization of high-end everything was an issue. Doctors were in that CYA attitude. Their costs for malpractice insurance continued to rise. They needed something that they could depend upon that was absolutely positively on spot. But what happened in doing that, they started doing MRIs when an X-ray was probably enough. And that became a problem. And all of a sudden, pre-cert comes into the picture. We talked about case studies, or they talked about case studies before me. So I'm going to show you, I'm going to give this a second to settle in. Total packages voided because of pre-cert, 1,469. Takes care of that little discrepancy in terms of what we left on the table, doesn't it? Why? Because in the pre-cert process, what happens is the physician calls it in to the pre-cert company, whomever that may happen to be. It doesn't much matter. Calls it in. In the time it takes them to get the authorization, the physician's already scheduled it at the local hospital. Now the authorization goes out, and if one call happens to be on the program with you, now we get the authorization, but the patient's already been scheduled. Now I've got to go back and say, well, that's all fine and good, but I can save you a lot of money. Yeah, but my doctor really wanted me to go there. I got it. But my doctors, I got it. But my doctors, I understand, but it's costing you money. And if it's not costing you individually out of pocket, it's certainly costing the plan. And if it's costing the plan, ultimately that plan cost is going to go up. And that's the problem. Look at some of the takeaways from just this. This is a pre-cert partnership workflow result case study for Cyprus. 21% of the voids occur because the patient's already completed the test. Done. Before we ever even get notified. Done. 12 of the voids occur because the patient's already scheduled for the test because the doctor said so. That's exactly why. And another 25 occur because the patient doesn't engage with us. You know why? Doctor said, yeah, no. I need you to go to the hospital. Don't pay any attention to them. This is where it has to happen. That's ultimately what happens. So based upon schedules versus voids and what the totals look like, this is it. And this, by the way, ladies and gentlemen, is Cypress. Only Cypress. I can go back and do this study against all of our clients across the whole of the United States. I'm going to tell you that the numbers aren't going to vary that much. A couple of percentages here and there. But it's a problem. The low success rate that we have is because of pre-cert. Is pre-cert bad? No, because it keeps an eye on a lot of things. It also goes to, which is another story, if you look at what we were talking about a little bit earlier about hard cost savings versus soft cost savings, if pre-cert is doing what pre-cert should be doing, they should also be identifying that which has the potential of becoming a catastrophic claim. And jump on that early enough to be able to catch it before that cost gets out of control. So there's a reason for pre-cert, but does it belong in all cases? And the answer to that question is no, it doesn't. So they go through this whole request, this whole process of identifying all that they have to, and then they talk about possibly getting into some of the other programs. So where is one call going with this tomorrow? Basically 3 different flavors of that which we currently offer right now, and what we're offering right now technically is only that high-end radiology of MRI, CT, and PET. We are about to introduce some of that which exists on the other side of the house, on the workers' comp side of the house. And what we're getting calls for right now, more than anything else, is transportation. We talked a little bit about that. PT, OT, DME, home health, and wound care. Those are the hot button pushers. Transportation we are currently doing now, as I told you earlier, in the Medicare and Medicaid space, and we're looking for how we're going to introduce that into the group world through our TPA partners. Most plans don't handle at all, and Tom mentioned this earlier, transportation in any way, shape, or form, sans that of emergent transportation. So how do you cover that? Can you get somebody to go and do this if you got them there and got them back? The probabilities are very good. Yes, that will happen. But the plan doesn't cover it. It's not in the plan, so how do you do that? And that's one of the things that we're working on. We're also working on, because we already have it on the comp side, about doing things that are outcome-based. Trust me, we report card. And anyone who's in a network business, report cards. We know who the good facilities are. We know who the good physicians are. We know where we're getting the best ultimate results. And we can drive them there. You can do that, but you have to have that proof. And so that's a whole nother level. So right now what we're looking at that's coming soon to a theater near you is 3 flavors of the product that I just described to you. It's the product that I described. It'd be one that would include transportation with it, and it's one that is outcomes-based, where there's a whole another component of clinical added to that. And you can have one of them, you can have 2 of them, you can have all 3 of them. That's entirely up to you. So that's coming. That's what we're in beta for right now. But ultimately, and at the end of the day, what I need to get to is to make everyone here understand that having the knowledge that all of this stuff is available, we're not carve-outs. We're carve-ins. That's what we are. And you need to keep that in mind. But more importantly, you can have somebody like OneCall, you can have Price MDs, you can have Renologic, you can have all of these great things, but make sure that they're working together, not against the plan per se. So if there's something that impedes you to make that cost savings, that cost containment, that outcome-based whatever happen, you need to look at that in the plan. That's the one thing that's missing in today's industry. We have consultants in the room. Consultants, raise your hands. Perfect. You know what I need you to do? I need you to start looking at all of this. What you bring to the table or to the brokers, you bring solutions. Do the solutions work with what is in place there? It's one thing to know that one's better than the other, but if it can't happen because there's something impeding that, then it's no good at all. And so you need to start looking at that. That's a component that's missing in healthcare today. We have all these great products around the room. Please make sure that you go see all of them, but make sure that they're working together. With that, I'm going to step back away from the hot light and questions in the room on anything. Two minutes.
I have, this is my ID card for our medical plan. And at the bottom of it, and I can't read because the lights are so bright, but it basically says,
Here.
if you, yeah, there you go. Oh, bright as day. If you need an MRI, a PET scan, or CAT scan, call this number, and it's the OneCall number. It's right on the ID card. Any provider should see it. Any patient should know about it. Yes, there is a question.
I do have a question. Ray, you had mentioned that the tool is based on cost, but not just cost alone, also it's outcomes based. So I'm just wondering what subset of data you use in order to determine quality.
Okay. Data primarily and where that's going. So, and right now that's available to us. It's not necessarily available to you, and we most likely won't go out with it, and I'll tell you why in a second. But we have all the outcomes. We know who those physicians are. We've been doing this since 1993.
Through what?
Report carding, following claims, what did it started out as and where it's going.
So it's your own subset of data?
Yes. Well, that coupled with data that we get from clients, especially those in, well, more than likely, in most cases, in the Taft-Hartley world, all the unions that are out there, they're always sending us the data. They want us to look at it because they're cost containment types of people. And so we're constantly doing cost savings analysis with that. So we have tons and tons of data. It's not just that which we did, it's that's coming in from clients of ours. Okay? Did that answer that question?
Kind of. I've got a question for the audience. Well, two things. Number one, thanks to this side of the room for actually asking questions. For that side, shame on all of you for not being engaged. But I've got a question for the audience. Does it? Oh, okay. My question is it me or did Ray throw Marcia and me under the bus in his presentation? I think he did. But anyway.
I told you I was going to do that.
Yeah, I appreciate it. So, all right, well, there is a question back there.
Hi, Ray. Thanks. Very good information. It's right here.
Oh, there you go.
Okay. So you were talking about the scheduling and how, they call, OneCall, make that, and the employee, the patient is in with the doctor. The doctor says, hey, you need to have an MRI or whatever. And they do go right away and, make the appointment at the hospital or whatever. What's the time frame if you're able to go, direct the doctor to go to OneCall? Give us an idea of what we can educate our employees about. Okay. How long does that take, that process?
It should only take a few hours for us to get it scheduled, but that's really dependent upon that which has to occur. Will the physician get back to me right away to verify the script? What time of the day did the call come in? If it came in at 5 o'clock your time and I can't reach Tom's office to verify the benefit, that's now got to wait until tomorrow. Once I have all that information, if that member happens to be still working, I've got to catch him during non-working hours. I can't get him at work. So that's it's about getting everybody connected and making those phone calls happen. So it can take as little as, believe it or not, as little as an hour. Generally speaking, on average, it's looking like 1 day. But I've seen it take as much as 3 and 4 days.
All right. Oh, this half of the room, right over here. We're breaking the barrier now, or we're entering into the left-hand side.
Yeah, I'm over here.
Yeah.
I see you.
So the question is, I've got the same thing on our ID cards for our employees for the one call. And so what if the provider says, I'm not doing that, and just proceeds, and piggyback on this previous question, they just continue to schedule their procedure with their own facilities?
Yeah, and the truth of the matter is that in some cases that occurs regardless, and that again, that's that behavioral change with the physician. At that point, it's incumbent upon the member to have gotten the education to say, whoa, are you going to take it out of your pocket? Because I'm not. I'm serious. I mean, they have to know this, that what's it going to cost that member? And ultimately, and remember we talk soft cost, hard cost. So you know what? If I go into my pocket and I say, this is mine. I took it out of my pocket. I know about that. What you need to educate them
By the way,
on,
that's a $1 bill that he's waving.
which I found on the airplane. I thought was lucky. I was going to put it in a slot, but never mind.
High roller. Man, you're awesome.
I stopped gambling in '78. But anyway, but what they need to understand is that it's affecting the plan. And as the plan experience continues to grow and becomes more expensive because of what they're not doing, not what they're doing, what they're not doing, then does it become affordable later on? So what happens? All of a sudden, there used to be, it was in network, my company's covering it, I get my benefit through my company, boom, done. Now they all have skin in the game. Everybody has skin in the game. And you don't see the one plan anymore. Now they give you the Chinese menu. For this much money, you can have the big one. For this one, you can have the middle one. And for this one, you can have, well, you can't. It's ACA. So there's all of that out there. When they begin to understand that their medical spend that they can drive is affecting the cost of the plan, you'll see that change, because that's when they're going to start pushing back on the physicians.